a vegetable. And so because of that, he has seizures. And they put him on some medication, and the medication is able to bring him into a place where he lives a kind of a normal life, because he's 32. He will be 32 next month, and he's married and have children, and he has not had any episode for a very long time. But that was one of the reasons he was on the medication, is to keep the episodes under control, and he's been able to live like that. And I think the tumor is not growing, because where it was, the doctor says it would be extremely hard to locate where it is, because it's like embedded into other things, and if you go in there to get it out, it will damage other parts of the body. So might as well just live with the seizures than to try get it out, because it wouldn't profit him in the long run. Amen. So sometimes that's the kind of hard call that they have to make. But we're here today and we're going to learn more. And at this time, I'm going to hand over to Rachel, because we know we're going to have some questions. We're going to get some good information. So welcome again to everyone on YouTube, Zoom, Facebook, Call Out Gospel Radio. We're very happy to have you. And we know we're going to have a wonderful time today. So I'm just going to hand over to Rachel. It's over to you. We're not hearing you.
You're not hearing me?
No, we never hear you. Still not hearing you. Say something, talk and let me. Are you talking? You must talk so we can know if you're.
Hello, good afternoon. Anybody hearing me?
No, we can't hear you, but you weren't saying anything before. We couldn't hear before. All right, now we can hear you.
Is anyone hearing me now?
Yes, we can hear you now.
Are you hearing me, Dr. Jones?
No, right now, yes.
Okay. Not sure what happened just now. I'm going to share my screen. Are you seeing my screen?
Yes, we're seeing the screen, types of children,
Okay.
types of children cancer.
All right. So yesterday we started on this. Good afternoon again, everyone. And we just want to continue. Hopefully, well, we should be able to finish today and go into some questions and answer section. But before we start, I know that the Holy Spirit was really among us yesterday. And so I just want to invite him again today in our midst. I'm going to ask Elder Dr. Jones to say a brief prayer for us as we go into today's.
Heavenly Father, we give you praise, glory, and honor. We thank you, God, for the privilege of being here. We thank you for the technology that join us together, God, in this fashion so that we can study your words and we can learn about things to improve our lives, oh God, while we're here on this earth. God, you want us to be healthy, wealthy, and wise. And so, God, we're getting this information to make us better, to improve our quality of life and that of our family, friends, and loved ones. Want you to anoint Rachel today to teach, oh God. Give her wisdom, knowledge, and understanding, oh God, that as she open up the earth presentation, God, we'll be able to understand, oh God. God, anoint us, oh God, and help us to receive your words today in Jesus' name. Amen.
Amen. Okay, so we're going back now. We're starting today we started yesterday, talking about some of the tumors that are in the brain. Some of them, we have pituitary macroadenoma, we have glioblastomas. There are lots. Some, as we said, are cancerous, which is actually malignant, and some are benign. That's the medical terms, which we say is non-cancerous. All right, but we are saying now that a tumor that starts in another part of the body and spread to the brain is usually called metastatic brain tumor. And that is so because it would have actually spread. So that would not have been the primary area where the cancer started from. With some cancers, sometimes the cancer has spread to a point that it's difficult to understand where was the primary point, where the tumor actually started from. So it says that tumors that start in the brain are called primary brain tumors, and primary brain tumors may spread to other parts of the brain or the spine. And we know when it gets sometimes to the spine, then you will actually have impaired neurological function. Same with the brain as well. And so some persons may have inability to walk or mobilize. Some will not have sensation to some of the limbs. It depends on nerves or where in the spinal cord the tumor is resting or where it has spread to. Often tumors found in the brain have started somewhere else in the body and spread to one or more parts of the brain. These are called metastatic brain tumor, as we mentioned before. So it may start at the frontal lobe of the brain and then it spread to the occipital lobe, which is the back, or it may spread to the parietal lobe, which is at the side. But whichever area of the brain, we have organs that is actually connected throughout the entire brain, like the brain matter. So it depends on where is impacted by the malignancy of this tumor, right, or this cell, then it's going to impact the movement, or for some persons it might be speech, some persons it might be smell, some persons it might be the sight that is affected. So some persons it might be the hearing. So it depends on which cranial nerve is being affected by this tumor or where the tumor lies. Now, these tumors sometimes, when they spread, they basically branch themselves out like trees, like three branches. That's the way sometimes of the cancer. So it starts at a point and then it starts to branch itself out. So when it branches itself out, just like we said that anything that is a mass, it basically takes up space. So it would be invading the space of other organs. And so sometimes it inhibits these organs to function at its maximum, right? And so when these tumors starts to spread, it depends on where it spread to. So we might have impairment in the kidney function, liver function, cardiac function, and so on. As we said, it depends on which organ systems is affected. And we said that metastatic brain tumors are more common than primary brain tumor. And as of course we mentioned, primary brain tumors is what is actually started at a point. And the primary brain tumors is said so because most of the time we fail not to catch it very early, and it would have actually started spreading to another area of the brain. Because sometimes it would have started out with a headache, and some persons may diagnose themselves and say it's a migraine, failing to go to the doctor to see what it is. And sometimes by the time they get there, then it would have actually started spreading, sometimes from the frontal lobe or wherever it is in the brain to another section, right? So it starts spreading, and each section of the brain is actually responsible for the bodily function. So it depends on where it has actually spread to, then that is the part of the body that is going to be affected. So it says up to half of the metastatic brain tumors are from lungs. And that's sometimes why most of the times why we tend to lose the patient. When it's spread, I don't know, it's always, most of the times it tends to, and it usually spread to the lungs before it actually, if it's the brain, it spreads to the lungs and it gets to the other parts of the brain. If it's tumor that has not started in the brain, it usually spread to the lungs and then also to the brain later on. But the lungs is usually one of the area in which the spread is actually when spread actually takes place. And this area is crucial because we know that once we have any spread or any mass that is occupying the respiratory system, then our breathing now becomes affected. And then it actually now prevents us from oxygenating properly and ventilating properly. So we might be taking in the oxygen, right? So we're breathing in, but because of the mass that is there and the damage that it has actually done to the lungs, so our saturation, which is the amount of oxygen in the blood, it's actually lower than what it is supposed to be. So normal saturation is between 95 to 100 in normal persons. For persons who have chronic obstructive pulmonary disease, sometimes we accept saturation sometimes like up to like 88, some persons 85. It depends on how badly the lungs is damaged, because those persons know the excess oxygen for somebody with COPD can actually push them over and actually cause them now to actually block out and into a state of death. That is because persons with COPD, they always have high level of carbon dioxide on board, right? So when you try to give them too much oxygen, it actually damages their oxygen drive, their CO2 drive, and so they become unconscious unto the point of death. So persons with COPD, we know that we cannot give them an optimal level of oxygen as we would normally give a regular person. But once the lungs is actually affected, then most of the time that person is going to require supplemental oxygen if it is affected to the point where their level of saturation has fallen. And we also know that most persons with cancer tend to end up with anemia, right? Because cancerous tumor are very vascular. They actually require a lot of blood supply to feed it. And so because of that, naturally persons with cancers are usually anemic. And so the oxygen, the hemoglobin, right? So we have in the body what is called, we call it oxyhemoglobin, because there are certain heme, and heme is actually the product that gives the blood cell its color, which is actually bind to the oxygen. So if the oxygen level is low, or if your hemoglobin level is low, your oxygen level is going to be also affected because of the binding capability that they both function at. So each hemoglobin is, I think it's actually 2 heme per oxygen molecule. So once you have that binding, when you're not having enough hemoglobin, then your oxygenation also is affected. All right. And these are some of the areas where brain cancer usually spread. Some is melanoma, then you have the breast, some it might spread to the breast, the colon, kidney, nasopharyngeal cancer, as that is in the nasal passages, as we know that the brain is right there. So it can spread easily through the sinuses. And then we also mention cancer of primary site, of unknown primary site, and which I mentioned earlier, that sometimes the spread is actually so grave, and when we find out it's too late, so it's actually difficult to tell where is the primary point, where did it start from? Sometimes we're unable to tell. So it says now, cancer may also spread to the leptomeninges, which is the 2 innermost membranes covering the brain and spinal cord, right? This is called leptomeningeal carcinomatous. The most common cancers that spread to the leptomeninges include breast cancer, lung cancer, leukemia, and lymphoma. And we'll go into lymphoma later on, which is also another type of cancer, as we mentioned. And this is it. So it's lymphoma is really a broad term of cancer that begins in the cell of the lymphatic system. And we have 2 main types. We have the Hodgkin's lymphoma, and we have the non-Hodgkin's lymphoma. The Hodgkin's lymphoma can often be cured, but the prognosis of the non-Hodgkin's lymphoma is dependent on the specific type. And for the non-Hodgkin's, you have various types as well. Okay, so the Hodgkin lymphoma is basically found in adults, and it says it's developed into the lymph system. And we know that the lymph system is a part of the immune system, which helps to protect the body from the infectious diseases. And that is why once it starts spreading to the lymph nodes, then the spread is going to be significantly at a faster rate, because now your immune system is going to become affected. And so it impairs with your ability for your immune cells to fight against the cancer cells itself. All right, this is very small. Let me see if I can bring it up a little bigger. All right, so lymph, as we said, it's really a colorless. Just want to emphasize what the lymph system is comprised of. So it comprises of lymph, which is colorless, watery fluid that travels through the lymph vessels and carries T and B lymphocytes, and these are actually white blood cells that fight in the form of the time of an infection, right? And here it says again, it's a type of red white blood cells. Now the lymph vessels, which is basically a network of thin tubes that connects lymph from different parts of the body, right? And here you would have it return it to the bloodstream. Now the lymph nodes, as I just mentioned, right? These are small bean-shaped structures that filter lymph and store white blood cells that help fight infection and diseases. All right, so we mentioned too that the lymph nodes are found along the network of lymph vessels through the body. And we mentioned those are like the connecting areas that the cancer tend to spread through, that connection, network connection. And think of a network, when you think of network, you think of connecting, right? So that is what role the lymph nodes play. And so sometimes once the lymph node starts to become swollen, the areas where you have lymph nodes, a lot of them might be palpable. So for some persons who have actually breast cancer, they will have what is called lymphedema. So the arm is enlargedly swollen. For some persons may say they have something that we call Waxan canal. That's the layman term that, you know, we tend to use. That was the word I grew up knowing. But it's actually the lymph nodes that is swollen, to say that there is infection present in the body, or there is some inflammation going on within the body. And now your B cells and your T cells are now in the T lymphocytes and the B lymphocytes are now trying to mount a response to fight against this infection or bacteria or whatever it has actually identified as the antigen. Now, groups of lymph nodes are found in the mediastinum, the area between the lungs, neck, underarms, abdomen, pelvis, and groin. And these are the areas where you find the lymph nodes. All right. Hodgkin lymphoma now most commonly forms in the lymph nodes above the diaphragm, right? And above the lymph nodes in the mediastinum. And the mediastinum is the area here where the heart is, in that little area. And we mention above the diaphragm. So now we see why the lung is affected because of that. Because if the area that is actually the spread goes first or goes to. The spleen now, remember I spoke about the spleen yesterday, which is an organ that makes the lymphocytes, right? Stores the red blood cells and the lymphocytes, filters the blood and destroy all blood cells. So remember we said that naturally your cells go through a period of repair, right? And the cells repair also based on our immune function. So if you lack in sleep and if your body is extremely stressed, that also will affect your inability for your cells to repair, right? To maximum capacity, right? So it is very important for us to have repair of our cells and rejuvenation of our cells so they can function optimally to help fight against diseases. The spleen, this is telling you a little anatomy now, that the spleen is on the left side of the abdomen near the stomach. And as we mentioned yesterday, that some persons, especially what I've seen, we have a lot of gunshot victims that come in and the spleens are affected. And so the surgeons have to remove their spleen, a surgery that they call splenectomy. Once they do that, though, of course, we know that now their immune system is automatically affected. And so these persons, we tend to give them, most of the time, we will give them a Haemophilus influenza vaccine, or we will give the influenza vaccine, because they are likely to get these conditions now, because the spleen is not really available now to make the white blood cells, which is one of the main driver that helps the fight in an infection. Now we have the thymus, which is an organ in which the T lymphocytes mature and multiply. The thymus is in the chest behind the breastbone. All right, the bone marrow now, and we spoke yesterday that some of the cancers are actually how we see how some of the cancers affect the bone marrow. And we said that the bone marrow is soft, spongy tissue in the center of certain bones, such as the hip bone and the breastbone. White blood cells, red blood cells, platelets are made in the bone marrow. All right, so we see that persons which have conditions or cancer that affects the bone marrow, their immune system is, those persons are going to look very emaciated and cachectic. They look very, very meager, right, or skinny, as you say, because they really have no resistance to fight. And sometimes what they can do, sometimes you have you find that mainly too in the first world country, or as we would say, the high socioeconomic countries, where they can do the bone marrow transplants. All right, so some of these conditions that affects the bone marrow, then a bone marrow transplant should be able to help with that. And we mentioned about the tonsils, which these are two small masses of lymph tissue at the back of the throat. There is one tonsil on each side of the throat, and the adult Hodgkin's lymphoma rarely forms in the tonsils. Now we know that some persons have to remove their tonsils as a child, because some of them become very problematic and painful. All right, but I mean, persons remove them and there is no significant issues with them. So the adenoids and the tonsils are surgery that persons often perform. They call it tonsillitis and adenoiditis. So they remove the adenoidectomy. So they remove the adenoids or they remove the tonsil, which is called tonsillectomy. So as we said, usually these conditions is where the benefit would outweigh the risk, because most of the time the doctors usually look at the situation and look at how the benefits outweigh the risk. So if it was a situation where removing these organs would affect you immensely, then they would have to think of a plan B. But of course, as we said, we have seen persons moving around who have done these surgeries and there is no significant problem that is happening. They live a normal life just like me and you, with our tonsils in or our adenoids in. So again, we're back at childhood cancer, and it says any of a large group of cancers of lymphocytes, white blood cells, the non-Hodgkin's lymphoma can occur at any age, right? And they are often, so remember we said that the Hodgkin's mainly affects adults, but the non-Hodgkin's lymphoma can occur at any age, right? And are often marked by lymph nodes that are larger than normal, fever and weight loss. So there are many types of non-Hodgkin's lymphoma, and these types can be divided into aggressive, which is fast growing, and you have the indolent, which is slow growing types. And they can be formed from either B or T cells. All right. So the non-Hodgkin's, those are more, those are the ones that mainly affect the children, the childhood population. It does affect the adult population as well, because as it said, it can occur at any age. So you have the B cell non-Hodgkin's lymphoma, which include Burkitt lymphoma. You have chronic lymphocytic leukemia, and then you have small lymphocytic lymphoma, right? It's diffuse large B cell lymphoma, and then you have follicular lymphoma. You have the immunoblastic large cell lymphoma, and you have precursor B lymphoblastic lymphoma and mantle cell lymphoma. Now, the name of the lymphoma, as we mentioned, is based on the origin. where it started from, right? And the T cells, so like the B cell non-Hodgkin's, as we said, that would have actually been found in the B cell. And we spoke about the B lymphocytes, which is one of the white blood cells that helps to fight or mount an immune response in the case of an infection or a viral infection and so on. Bacterial, viral, it might be fungal, it might be as a result of a protozoa. With whatever kind of infection that we're gonna have something triggering a inflammatory response, because inflammatory mediators are released when there is an infection on board, and that is because of your body natural cells now start to fight. Okay, so it would have sensed that there is an infection present, and then it starts mounting in its response to fight. The T cells non-Hodgkin's lymphoma now include mycosis, fungoids, anaplastic large cell lymphoma, and precursor T lymphoblastic lymphoma. It says lymphoma that occur after bone marrow or stem cell transplantation are usually B cell non-Hodgkin's lymphoma. Prognosis and treatment depend on the stage and the type of disease. So it would depend on the type of non-Hodgkin's lymphoma that you have and the stage. We know the stage is important. So catching it at a stage 1 or a stage 2 is better than it's spreading to a stage 4, because we know that the stage 4 is actually the detrimental phase. I've heard on the prior line person mentioning stage 5, but I've not known anything other than a stage 4. I need to go back to my research. I think stage 4 is usually to the stage where it has spread to all the organs, and that stage is where you're gonna now have deaths. As we said, unless it's a divine miracle, but the stage 4, we know that your time has shortened. So you can actually prepare yourself at that time, you know, to make provision, as we said, if you're not spiritually healed. The disease caused by the human immunodeficient, the virus, which is HIV. And we said that people with AIDS are at increased risk for developing certain cancers. And we mentioned the link yesterday because of the fact that the AIDS, now the AIDS would have been an advanced stage of the HIV, right? So when it reached the AIDS stage, it would mean now that the immune cells are so low, right? It would have been 200 and below, and that the viral load, which is telling you now, the viral load tells you how fast the virus is multiplying, right? So of course, if you have the viral load as very high, much higher than the immune cells, then you're going to have problems. So you're now at this stage, and so your body really has no mechanism to fight anymore, and so you tend to get all the opportunistic infection, right? Especially now with the stressors of what is happening with the cells from some of these viruses, you automatically now end up with a weak immune system, and so you end up getting immunodeficiency syndrome, right? Which is a whole cascade of events starts happening, right? Until automatically death will occur. All right, so this is actually this should be development. And we were speaking yesterday about the types of leukemia and the other cancers, and we're saying that most of the cancers, well, cancers are basically named where based on the origin, where they are originated from. Yeah. All right, so we have cancer that affects the red blood cell, and cancer in itself is going to affect the red blood cells because these masses are going to affect the level of oxygenation in the blood, because most persons tend to become anemic because of the fact that the cancer cell in itself actually takes up a lot of blood supply. So that is what actually accounts for the anemia. And we have the neutrophil, eosinophil, those are actually basophils. You have the myoblasts and so on. So the eosinophil, the basophil, and the neutrophil, those are different types of red blood cells. And over here where you have the lymphoblasts and the lymphoid stem cells, then you have the B lymphocytes, which is one of the white blood cells. You have the T lymphocytes, and then you have the natural T killer cells. So these are the cells that helps you to fight in a situation where you're having an infection on board, right? Of course, we see the red blood cells on the left and the white blood cells on the right. Now, both of them actually plays a vital role in the immune response and you keeping good health during being diagnosed with cancer. Because as we mentioned before, once your hemoglobin level is going down, then your level of oxygenation is also going to be affected. And of course, that's happening for over a period of time. You tend to now start getting heart failure now because the heart now have to be overworking to try to get out that volume of blood now that is not there because the oxygen concentration is so low, and so the oxygenated blood is also affected. Low platelets or platelets too high, as we mentioned, that platelets is actually that component of the blood that allows for the clotting when you get a cut. So if the platelet levels are extremely low or the platelet levels are extremely high, so it will be your inability to clot effectively. And so if you even get a needle stick, sometimes we have patients that if they're on blood thinners, sometimes these blood thinners sometimes will affect their platelet levels, or it will affect their clotting factor, which is their prothrombin and their prothrombin time. So that is actually a time stipulated by the lab based on your blood, and they will see how long the blood takes to clot. Now there's a criteria and a time frame. So if it's going beyond that or it's clotting too fast, then we know that there's a problem. So we have to give treatment to actually remedy that. Now we have patients that we just give them natural injection, and because it's an intramuscular injection where it is required to use a larger bore needle, just from that simple stick, we notice that they just bleed and they bleed. What we have to do at that point in time is to arrest the bleed by putting on a pressure bandage on the area for possibly a few minutes probably, and apply pressure until the bleeding has subsided. All right, so it says blood cell development. A blood stem cell goes through several steps to become a red blood cell, platelet, or white blood cell. And now we see why some persons, it depends on the type of cancer, they're both required to do chemo along with stem cell replacement. So it's like they're actually detoxing the body, removing those cells and putting back fresh stem cells within the body itself. That's a part of the stem cell treatment. All right, I will mention this yesterday. Some of it's essential to prescribe therapy for the type and extent of disease. And we mentioned that you have different treatment modalities for different types of cancers, and also the dosing and the treatment too would also be depending on how aggressive the tumor is, and sometimes the stages that it is at and the types. All right, so standard. So these are standard. We mentioned that you have chemotherapy, surgery, or radiotherapy. And you may have, for some persons, based on the type of cancer, chemotherapy along with stem cell treatments. So as we mentioned, your nutritional status, here it goes everything. You can't overemphasize your nutritional state. It's very important, which requires a dedicated multidisciplinary team. So that was when we mentioned yesterday that once you have cancer, it cannot just be the oncologist, right, that is looking about the chemo drugs or the radiotherapy and so on. Now we have to factor in nutrition, right? We have to factor in probably the medicine team that is gonna actually monitoring your oxygen level. It might be, it depends on how severe it is. It might be ICU. However, in our practice, usually for us, there is a criteria for us to take patients in ICU. So if your condition is a chronic condition and we don't think that it gives you a good chance of survival, then of course we're not going to accept you. So some form of cancers and so on that we know that the prognosis is poor, we don't really take those patients in the ICU, because it's like they're saying your prognosis is already poor. So especially we know that ICU in Jamaica or most first world countries, there's always a space issue, right? Because we have more persons now becoming critically ill. There are times when you have the count load in ICU that is low, But we're saying if we're supposed to take on all of these cancer, when somebody else is come, that's what they're saying, that you can actually give them a fighting chance to survive, then you don't have an area to put them. So that becomes an issue for us. So we have to make a call to see which is the more crucial patient that we would take, or which one prognosis look better. So that's that sort of thing. All right, so this is talking about now mycosis fungoides and Sézary syndrome, which are diseases in which the lymphocytes, right? And we mentioned that's a type of white blood cell becomes malignant, right? And here in brackets, it's saying cancerous and affect the skin, right? So that's how it meant the word fungoids came about, and mycosis. So it's the skin. Normally the bone marrow, as we said, make blood stem cells, right? Which is the stem cells are really immature cells. That's a myeloid that becomes mature blood stem cells over time. All right, so it starts at immature and then it moves to a mature stem and blood stem cell over time. The blood stem cell may become a myeloid stem cell or a lymphoid stem cell. A myeloid stem cell becomes a lymphoblast, and then so it's another stage of the white blood cell. That's the lymphoblast. It goes into another stage. And then one of three types of lymphocytes, white blood cells. So you have the B T lymphocytes, B cell T lymphocytes that makes antibodies to help fight infection. Then you have the T cell lymphocytes that helps the B lymphocytes to make antibody that fights the against infection. So these lymphocytes actually work together to mount an immune response and fight against any virus or bacteria or fungus, whatever foreign that we see come to the body. Natural killer cells attack cancer cells and viruses. So if you notice the diagram that we showed earlier, it was also speaking about the natural killer cells. All right, and those are the cells that will actually target cancer cells and viruses. And they actually know the body is programmed like that because they identify these cells by their shapes, right? And so on. So the body can actually, once it's anything foreign, then the body is naturally going to mount a response. And that is why even with some persons tend to have a miscarriage, because sometimes once that the bodies, for some person's body, it will see the fetus as something foreign to the body, and so it start mounting a response, and so some persons will have a spontaneous abortion. So the baby, they will just lose that baby naturally without them doing any interventions or taking any form of medication. Now, treatment, access to effective diagnosis, essential medicines, pathology. So the pathology has to do with the disease process, the blood products, radiation therapy, technology, psychosocial and supportive care are variable and inequitable around the world. So all of these are what we need to really help in the fight against cancer. However, cure is possible for more than 80% of children with cancer when the childhood cancer services are accessible. Pharmacological treatment, for example, includes inexpensive generic medication, right, included on the WHO, which is the World Health Organization list of essential medicines for children. Some persons will think that the generic brand does not work as effective as the original brand. So it's the same medication is in it, but most of the time with the generic is basically sometimes like a copy. So it doesn't work as best sometimes as the original would have worked. And the generic sometimes, well, the generic at all times is usually it's cheaper, it's more cost effective. And we know that children who complete treatment of cancer, they require ongoing care, monitor for cancer recurrence because the cancer can reoccur, and to manage any other possible long-term impact of treatment. Now, some of these impact of treatment, we know that you might have ear loss for some, you might have weight loss, It's a whole lot of things. So that is why we need collaborative care with your nutritionist or your dietitian. You might need for your dermatologist. It depends on how much burn you have to the skin for the radiotherapy, because the radiotherapy can be very harsh for the skin. The chemotherapy might give some person's body image disturbance because of the fact that they lose their hair. So a lot of them tend to go bald, and they might be walking and persons looking at them strange. But thank God for wigs. So in that case, a lot of persons will wear a wig because, as I said, it's a body image disturbance. For some person's self-esteem is not that high, and so they will tend to feel very bad for the fact that they're having hair loss. So wearing a wig can help to alleviate some of these anxiety and the pressure that you feel from going bald from the chemotherapy. All right, so chemotherapy treatments. We know that chemotherapy are drugs, right, that are administered intravenously. So we give it through the veins, right? And these attack fast-growing cells that compromise most pediatric cancers. Pediatric cancers tend to respond better to the chemotherapy than cancer in adults. However, as we said yesterday, the chemotherapy kills healthy cells along with the cancerous ones. So you're trying to get rid of the cancerous cells, but it depends sometimes on where the cancer is. You're automatically going to damage some of the good cells as well. The side effects of chemotherapy can be grave. You will have nausea, vomiting, low blood counts may occur sometimes, along with other long-term side effects. And some of these other long-term side effects, as we mentioned, are infertility and nerve damage. Because as we mentioned, the chemotherapy is grave and the radiotherapy can be very, 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 very harsh. So as we said, long-term side effects, infertility and nerve damage. But of course, in situation like this with somebody with cancer, and it depends on the type of cancer and so on, as we said, you would have actually been doing your monitoring over time. So you would have done a series of scans over a period of time. So that would help the doctors to ascertain how fast the tumor is growing. And if they don't think it's growing fast enough to raise an alarm and to the point where it's causing any neurological deficit, then as we said, then it makes no need to trouble it. So for persons with chemotherapy, chemotherapy drugs are very chemotoxic, as the name suggests. A lot of them are nephrotoxic. And so they will actually damage the kidneys. And for persons who are pregnant and going through chemotherapy, of course, naturally, those drugs are going to be harmful for the unborn child. So in a situation like this, the doctor would advise you to not get pregnant at that point in time while you're on the chemotherapy, because the drugs can be very fatal for the unborn child. Radiation is also used to treat pediatric cancers. Children, all right, so this is where we have the children lie on the table while there's an X-ray beam, right? Target that tumor, right? So for the children, we have to try and keep them young because a lot of them are anxious and fearful. And because of the fear and anxiety, they fail to stay still, right? So that might be a problem. All right, so it says to keep young children still, you maybe have to sedate them. So sometimes we have to give them drug to put them to sleep, right? And this is the process. This is what anesthesia has to do with, because you don't want them to be going through the fear and the anxiety of seeing you, right? Giving them some of these treatments. I mean, the radiotherapy, just by seeing the machine and going under the machine, it can be traumatic for them. My daughter recently did a CT and I wasn't able to stay in the room with her, because what we don't do, sometimes we can put on the coat and the lead jacket that actually helps to protect you from the amount of radiation that you're going to be exposed to, right? But of course, it was a very fearful moment for her, seeing her going under that big machine. But what I tried to do is explain to her throughout the procedure, pray with her so I could alleviate some of the fears. But just think about it. For the MRI, there's a lot of noise. that the machinery makes. Sometimes you have to plug your ears because of the amount of decibels your ears is actually exposed to the noise decibels that can actually damage your hearing. So it is very important. But the MRI machine is a lot of noise, and you're constantly going through, and while you're going through, it's actually scanning that area of your body, whichever the mass is, that it would scan that area of the body. And it depends on the tumor or whatever is happening in the body. Sometimes an MRI is better because it actually shows the finer details of whatever is happening, right? In some instances, it depends on, for instance, for example, bony structures and so on. It depends, not involving many tissues and so on. Then a CT would have actually been a better test to do. All right, so it is very important as well for the doctor to explain the procedure to the patient. So this is what we do when you actually, you're trying to get them to be comfortable. So you're telling them what you're about to do. You have to involve them in the care. They will decide if they want to do it or they don't want to do it, because remember, it's not like you're going to force them or impose on them. But once they agree, then they sign the consent form and you proceed, right? But one should not proceed in going to do a surgery if you have not understand what the doctor is saying. For some persons, they will understand, they will explain, sometimes thinking that they're breaking it down. I mean, a lot of the times we as medical persons, we don't really assess the knowledge level of that person. And so sometimes we use the medical jargons and the patient don't really understand. And my take on that is that usually you're not going to get compliance if you don't understand what is happening with them. It's always best to explain what is happening, explain the treatment modality and what you plan to do, right? And you also tell them about the outcome. You would also want to tell them about what are some of the signs and the symptoms, you know, or the effects that they might feel as a result of doing some of these procedures. Now, the palliative care relieves symptoms caused by cancer. Now, when you hear about palliative care, this is when the cancer has now spread, and we as caregivers or the oncologist team, there is nothing more that they can do. So what we tend to do is we try to improve the quality of life, right, for the patient or the family by we give them their pain medication, of course, and a lot of them are on many narcotics, which are actually drugs that actually put them to sleep and alleviate the pain. But when we get to the end stage where we need palliative care, sometimes you will get the medication, you take it 2 hours ago, and then you start getting a relief probably for half an hour, and then you're gone back to square one, right? Because the cancer has spread so far and wide, and so it affects the ability of the organs to function. And as we mentioned, sometimes it depends where this tumor is. So the person may tend to actually have a lot of pain. We said that, right, I think I said that yesterday, that so this is saying that assess adequate assessment to oral morphine, and this is the main drug of choice that we tend to use for our cancer patients. It's a narcotic drug. Now, we don't just give them one medication, because this one medication alone is not going to control the patient pain. So you would have to give them a series of medication at different times, because what you're trying to do is to control the breakthrough pain. So if you give them the morphine now and another one is due to another 2 hours, the doctor would probably set it like that, because they know that probably by the other 2 hours, then you might be having a lot of pain. However, whatever is stipulated by the doctor, they usually tend to do their assessment first to arrive at that conclusion as to what to do. Now, this is the WHO response, and it says in 2018, who had launched the support of the St. Jude's Research Hospital, which is the global initiative for childhood cancer. So St. Jude's Hospital has been one of the hospitals that has been very instrumental in treating children with childhood cancer. It says, and it helps them to provide leadership and technical assistance to government to support them in building and sustaining high quality childhood cancer programs. So we get them into various programs, and so it does not take from their way of life or their opportunities in life. I mean, some of them will be delayed a bit because it depends on the severity of the cancer or how far the spread is. But the main aim really in this point in time is to support. The goal is to achieve at least 60% survival for all children with cancer by 2030. And this represents an approximate doubling of the current cure rate and will save an additional 1 million lives over the next decade. So this is what the World Health Organization has declared based on their study of seeing carrying out basically a lot of evidence-based practice, right? And launching this at the St. Jude's Children's Hospital. So we see what is happening here. All right, so the WHO response again also has a cure-all framework, and its accompanying technical package have been developed to support implementation of the initiative. The package helps government and other stakeholders assess current capacity, set priorities, generate investment cases, develop evidence-based standards, and we need that because it doesn't make sense we come back blindly and tell somebody about a medication. It's best we do our evidence-based practice, and that is actually done by carrying out our research. Information sharing portal has been created. You can go on the WHO website and read up about this, where it relates to childhood cancer, to get additional information. And their response continue in 2021. It says that WHO, which is the World Health Organization, and St. Jude's Children's Research Hospital, they launched a global platform for access to children cancer medicine, the first of its kind to provide an uninterrupted supply of quality assured childhood cancer medicines and end-to-end support from selecting to dispensing medicine according to the best possible care and standards available. All right, so we talked about this yesterday, the clinical trials. Now, as we mentioned, you always hear of persons asking about new medicine. I mean, sometimes these drug company, they're putting out a lot. I mean, they're trying to get sales, and some of it is to the extent of other person lives. However, for the clinical trial, you do have persons who have volunteered, right, to be a part of this group, which I call it a group basically of guinea pigs, because it would have been that a drug that they're actually trying over time and they see that it works. I know that in the past, a lot of these things we usually do with animals, right? But now we've seen where they're just trying, error and testing within this platform. All right, so clinical trials, as it says, research study is found to be safe and effective in treating diseases. Clinical trials for children and adolescents with cancer are generally designed to compare potentially better therapy. So as I mentioned before, it's like you're trying to see which one of the treatment modality is better. So you might have a new drug. So the drug company might say, I have a new drug that I think can actually cure cancer. And so you buy into it. So you start doing the testing because, of course, now you would want to actually do this testing, or whoever is selling the product, so they can show you that, listen, this is what they're observing. So, and I'm sure nobody wants their relative or themselves to become a guinea pig. I mean, if somebody dies and you want to do organ transplant or some other thing, that's different. Donate your organs for that, that's different. But other persons believe that the same way they came to God, that's how they're gonna go back. So some persons don't really believe in the transplants. All right. It says clinical trials for children and adolescents with cancer are generally designed to compare potentially better therapy and therapy that is currently accepted as standard. All right. Most of the progress made in identifying curative therapy for childhood cancers have been achieved through clinical trials. So it means then that they don't necessarily probably do these trials on children, right? But, you know, somebody might volunteer and said, okay, you can try it on me. And I'm thinking that you would have actually gotten these persons to sign a consent form to say that they would have given their consent to be a part of this guinea pig study, I call it. All right. Treatment side effects. Children face unique issues during their treatment for cancer, after the completion of treatment, and as survivors of cancer. For example, they may receive more intense treatments. Cancer and its treatments have different effects on growing bodies and than adult bodies, right? And they may respond differently to drugs that control symptoms in adults. Late effects of treatments are discussed later. Right, and as we said, you can go to the page on WHO and see all about this. All right, and we mentioned now that children who have cancers are often treated at a children cancer center, right, which is a hospital or unit in the hospital that specializes in treating children with cancer. So this would have been the oncology department, right? So they deal with the radiotherapy, they deal with the chemotherapy, and other a combination of chemo or the stem cell therapy. The doctors and other eye health professionals at these centers, they have special training and expertise. Like at my institution, we have oncology nurse. They are training that area to look about the cancer patients, and so they learn about the drugs. They learn how to administer the drugs and so on. These drugs are highly, as we mentioned now, they're highly carcinogenic, so they can also cause cancer. So sometimes you have to be keen. You have to be keen on how you handle it. You have to be very careful when you're handling these bags or apparatus that is used to give treatment. We said that specialists at the Children's Cancer Center are likely to include primary care physicians, pediatric oncologists, hematologists, pediatric surgical specialists, radiation oncologists, rehabilitation specialists, and that we know that after you would have come from the chemo, some persons are not able to walk as they would have. Some persons, it depends, some persons it might be their speech. So you would have some form of rehabilitation to help to get you back, you know, functional into society. We mentioned again about pediatric nurse specialists, social workers, and psychologists. Now it's very important. So for me, I can nurse a child, you know, I'm a midwife, I am an RN, but sometimes with the care of pediatric care can be so much different, right? Across the board, because as I'm saying, that you would have the level of expertise for each of these specialty area. And so your level of expertise and knowledge will depend on the treatment that the patient gets and how effective is the treatment, right? And we know that these centers, as we said, are actually where you will have clinical trials available, and sometimes those are actually at the area where you have these cancer patients. Now, it's always a challenge coping with cancer, right? How do we adjust a child to this new diagnosis? You know, finding ways to stay strong, sometimes as the parent or relative, and at the same time encouraging that child and being their support system, you know. But we know that we have support groups. I mean, you can talk to your pastor of the church. If you have a close friend or relative, you can actually share with them how you're feeling. I mean, they will help you to cope during this difficult time. For some persons, if you feel like probably going to the park, you know, and unwind for a little, or going to the beach, of course, not leaving your child unattended to for a very prolonged period of time. But sometimes a little of those therapy might be important, you know, for you, you know, a little masseuse and so on, just to help to relax your mind. I mean, prayer can't be overemphasized, because I mean, that is what is going to give us spiritual hope, and hope that you know, this person have another chance of surviving, or can cope with the fact that you know that you have a brain cancer, but you're not really worried at this time. All right, so survivorship now. So this is really, it's essential for childhood cancer survivors to receive follow-up care, right? You monitor their health status, ensure that they're completing the treatment, because you don't want to start the treatment and then you're not continuing, because then wherever you stop, that the cancer may become more aggressive now to the treatment that you're giving, and so it doesn't respond as effectively anymore. So you have to be careful how you break the therapy, the treatment therapy. All right. Right, so it says any kind of cancer can develop health problem months or years later after getting the cancer, after getting the cancer treatment, and these are known as the late effects. But the late effects are of particular concern for childhood cancer survival, because treatment of children can lead to profound, lasting physical and emotional effects. The late effects varies with the type of cancer, the child's age, and the type of treatment and other factors. And these are my references. So feel free to go on and, you know, just read up
I have some
about it.
questions for you, Rachel. You mentioned St. Jude, which is a research hospital that help. Does St. Jude provide medication and services like to people all over the world? Like if a Jamaican child have cancer, can they apply to St. Jude, and when they're accepted, just come from Jamaica up here for treatment, because everything is free for the child and free for the parents to stay. They provide places for them to stay for free.
Well, I think they have they allow for this type of service. I am not so sure how the transfer. I mean, yes, and it would depend on a number of factors, because I now think that you would have to get a medical report from your doctor to see, you know, what is the reason for you getting this treatment. And yes, they do have a lot of inexpensive medication, that generic medication that can be offered, and that is usually offered to help with this.
Help children, all right, because most hospitals here don't just have a unit for the children cancer, they have an entire hospital. So you will have, like, for example, where I am, you have Memorial Hospital, and then you have a Joe DiMaggio, the cancer unit separate. They have their own hospital just for that. They have because it's a problem. Another thing, can you offer like herbs? Somebody wants to know, can you offer herbs to children, or is herbal treatment effective in children?
As I always mention, any form of treatment that you're going to do, it's always best to discuss it with your primary physician. And not just the primary physician in this point too, you would also, if it's a situation where you're now confirmed that you have the cancer, then it is also good to speak to the oncologist, because sometimes some of these herbs, even though they're natural occurring herbs, they do have properties sometimes that can inhibit the pharmacological effects
Medication
of the other drug, right? So it's always best to seek medical advice where that is concerned. Herbs in itself, too much of it damages the liver, because it's a lot of work on the body for the liver to be detoxing. So if you're even taking herbal medicine, it has to be in moderation, and it can't be too much, because you'll be treating one thing, but then at the same time, your liver is going on the other end.
All right, I have another question. Is there, apart from AIDS and HIV, is there a connection, like, for example, with other autoimmune disease, like lupus and those things? Are there,
yes, there is a connection, because it is. Because remember now, with lupus, it's actually yourself fighting against each other.
Fighting against the body.
So it's in other words, then you have your natural cells, and it is attacking these cells as an hazard. And so it prevents now that ability of any cells at all to fight, because there's a constant war going on. And so usually with lupus, you find like you tend to have multiple organ failures because the organs now start failing because of this. So of course, those persons are going to be affected significantly as well, because now their immune system is going to be affected because they don't have that response to fight.
Okay.
The same for diabetes, which is why yesterday I said that there is
Right,
some need for
yeah.
some persons with diabetes. You might notice that they will get some form of cancer as well, because it's actually because of the weakened immune system. And these are actually condition: diabetes, HIV, systematic lupus erythematosus. Those are conditions that actually compromise the immune system. And anything that is compromising the immune system is going to put us at risk, you know, to develop cancers and other problems.
All right, one last question, because we're way over time. Is there any way to cut off the supply to cancer cells? I remember a couple of years ago that Israeli, they were trying to develop a form of chemotherapy that could identify the abnormal cells. So instead of destroying the good and the bad cells, and hope the person can recover, and then the good cells come back up, and they were trying to develop some medication just to identify abnormal cells, so that the medication will work just to destroy the abnormal cells. Do you know if that medicine, are there any medicines available that can just identify the abnormal cells and then mitigate the damage that chemotherapy do to the body? Because chemotherapy destroy your immune system, because it kills the good and the bad cells together.
I think there is
the
stem cells. The stem cells, sometimes there's a stem cell treatment that can be used. They are trying to get to that level of chemotherapy treatment that can be used, but there's always a factor where some of the good cells are being damaged just the same.
Okay. All right. Because that is the major problem, is when the good cells get damaged. And then the difficulty with children now is that their body is growing and developing. So how can you, I mean, with older people, you know, basically you're grown, you have your teeth and you're not changing. But in children, their body is changing and development. So how can you come up like with a precise formula of treatment when their body is growing and changing at the time that you're even prescribe a path to care, and their body is changing while you're trying to treat them?
That is what makes it so difficult, because it's not a one size fits all. So there's a lot of factors that you have to look at in terms of, like, for the children, you have to look at the dosing, body weight. As we mentioned, you have to look at the types of cancer, how aggressive is the cancer, the stage of the cancer. So I guess that is why they have actually been doing ongoing research, because these are things that they really want to get to this point where they can actually get to the cancer without damaging so much of the good cells. Yes. And for the children who are actually so vulnerable in all of this, because of the whole developmental phases that the body is going through, with hormone being actually being so involved as well, making the situation sometimes worse. But in all of this, it still depends on the stage in which you catch it, right? And where it is, and the extent of it, and so on. As we mentioned, with the children, it's very technical, because you have to look at the body weight. And so, as with a child weighing probably 100 pounds, another child weighing 80, then you have to look at the dose. Because even with radiotherapy, they don't usually do it for more than 30. They don't do it for 30 minutes. They try to do it like under 30 minutes, because it is so grave. There's the radiation will burn you. Burn up the body. So what they will do, they don't go over 30 minutes per day, but they will do it like in a series of days. Like, say they'll do it say probably more than once for the week, but they cannot exceed 30 minutes. They don't even go up to 30 minutes, because it is so grave on the body. I mean, you will hear people telling you, giving you the testimonies of how they were burnt with the radiotherapy.
Literally on the skin.
Yes.
All right, thank you so very much. Everyone, remember, there is a prayer request. Someone has a prayer request in the prayer line. Just take a screenshot of it, and we will be praying for you over the situation. And remember, tonight I teach the Light to the Nation in Curacao, and it begins at 7:00 Eastern Standard, 7:30 Eastern Standard Time. Tonight will be our last prayer meeting at 6:00, praying for Jamaica. And if you have not been praying, today is the last day for the fast in the 3 days fast for Jamaica. So thank you all so much for praying for Jamaica. Let's continue to do so. God bless you. Amen. I'm signing up now. See you on Thursday as we continue Romans. And thank you so much, Rachel. That was an excellent presentation as usual. And let's share the
That's all,
information.
God.
Right.
That's
Share
all
the
the Holy
information.
Spirit.
Right. Share the information with
I will share it in the group.
Right.
I realized there was a lot of typo error because I was sleeping halfway, but I'll fix it and send it.
That's all right. God bless you. All right. See you all on Thursday, God's willing. Bye-bye.
So it's 7:30, you said today. 7:30 Jamaican time?
Eastern
No,
Standard. No,
that's your
Jamaica,
time.
that would
Okay.